Hi, my name is Saar Baert and I support different projects of Médecins Sans Frontières in the Southern African region. Today I want to share with you our lessons learned from the implementation of a patient-driven model for HIV care called Community Art Groups or CAGs. This model has been developed to address barriers to accessing HIV care as experienced by Mabaruti, a young HIV-positive woman from Lesotho. Mabaruti travels miles every month to the health facility to pick up her drugs. She then spends a full day waiting in the queue to pick up her drugs from a nurse who is struggling to deal with a huge patient load. That is why in 2008 CAGs have been piloted in Mozambique. A CAG is a self-formed group of 3 to 10 stable patients on ART from the same community. They meet on a regular basis at the house of one of the CAG members to provide peer support to one another and to organize their drug refill. On the ART refill day, the members will check whose turn it is to attend to the health facility for a clinical consultation and blood drawing. This CAG representative will pick up the drugs for all members at the clinic. At his return from the clinic, the representative will meet up with the other CAG members to distribute their drugs. Based on promising outcomes of community art groups in Mozambique, this model has been rolled out to other rural settings in Lesotho, Malawi, South Africa and Zimbabwe. Now let us have a look at what benefits CAGs have brought to these different settings. First of all, CAGs have reduced the workload for healthcare workers. When comparing clinic attendance before and after joining CAGs in Malawi, we observed a 69% reduction in ART refill visits. At the same time, the number of other visits, such as for malaria or other acute problems, nearly stayed constant. Patients thus continue to attend the health facility when the need is there. CAGs have not only reduced the burden for healthcare workers, but also for patients, as is shared here by one of the CAG members in Lesotho. CAGs help patients to reduce their transport costs and give them time to do other duties because they need to attend to the clinic less often. In Tet, Mozambique, 98% of CAG members were still retained in CAGs after 2 years. Similar high retention was observed in Malawi and Lesotho. A pilot in Xangara, Mozambique also shows us how CAGs could contribute to improve testing and linkage to care. Through the CAG network, community counsellors are able to offer HIV testing to family members or other peers of CAG participants. Since early 2013, more than 3,000 persons got tested in Xangara, of whom about 9% were HIV positive. Of those eligible for ART, 89% started ART at the closest health facility. This CAG member from Lesotho explains us how community art groups are also a source of peer support for its members, as the members will now look for solutions together in their community. Although CAGs provide many benefits, not all patients are willing to join a CAG. We see that participation in CAGs is especially high in rural areas. While nearly 50% of patients on ART in Tet district in Mozambique were in CAGs in 2012, only 13% of patients in the district capital city chose to join a CAG. A similar lower uptake is observed in urban Maputo, where today only 20% of active patients on ART have formed CAGs since its rollout in 2011. Now, what makes CAGs function across all these settings? From the rollout of CAGs in different settings, we were able to identify a number of critical enablers that are needed in each of these settings for CAGs to function. First of all, CAGs have brought along new tasks, such as establishing, training and support of CAGs. These tasks are mainly performed by lay workers, such as community health workers or lay counsellors. In reality, these lay cadres are often not recognized within the Ministry of Health, or they lack financial support, such as is the case in Mozambique. This poses a serious threat to the sustainability of CAGs who rely heavily on this cadre. Another important element of CAGs is provision of support to CAGs facing difficulties, a role typically taken on by these lay cadres. Routine supervision of CAGs has not deemed feasible due to workload or transport constraints. Therefore, triggered supervision of CAGs is being piloted in Lesotho and Malawi to reach out to the groups in need. A third critical enabler is the monitoring and evaluation system, which is needed to follow up on the outcomes of patients in CAGs. These tools need to be simple and are ideally integrated into existing national M&E tools, like is the case in Zimbabwe, to avoid an increased workload for healthcare workers. Another essential element is the need of clear referral mechanisms to clinic care. Patients will attend 6 monthly or annually for a clinic visit, and they are educated on when to refer back to the clinic. Clear criteria are needed, such as in the event of suspicion of treatment failure or the development of opportunistic infections, to refer patients back to clinic care. A fifth and final essential element is the need for a reliable drug supply, as supply chain weaknesses undermine the advantages of CAGs for patients. Similarly, longer-lasting drug supplies increase benefits for patients who will need to attend less often to the health facility, as is the case in Zimbabwe. This guides us into the question of what elements might not be vital for CAGs to function, but are opportunities to further increase benefits for patients and healthcare workers. An important opportunity for CAGs to become more than pure refill groups is through interaction with or support from local HIV networks. These networks play an important role in the establishment and promotion of CAGs in Lesotho and Malawi. They can also link CAGs to income-generating projects and advocacy initiatives, as is the case in Zimbabwe. CAGs have been implemented for stable patients on ART, and Viral Load assists healthcare workers in South Africa and Zimbabwe to easily identify who is stable and can thus participate in CAGs. Similarly, Viral Load enables the nurse to identify who is at risk of drug failure and should be recalled to the clinic. Now let's conclude and have a look at our way forward. Community art groups have shown to provide a number of benefits from the perspective of healthcare workers as well as from the patient's perspective. Further documentation of these outcomes is ongoing to inform policymakers and implementers in the field. Further advocacy targeting international, national and subnational policymakers will be needed to ensure critical enablers for CAGs are in place, such as lay workers, reliable drug supply chains, monitoring and evaluation tools, and clear referral mechanisms for support and clinic care. Currently, CAGs serve the needs of stable patients on ART. However, we are working towards inclusion of other groups at high risk for loss to follow up, such as pre-ART patients, unstable patients on ART, adolescents, and pregnant women. As part of documenting the experience, we also need to further simplify our tools and procedures to ensure easy adaptation and integration of CAGs into other settings, such as systems for triggered supervision and the inclusion of CAG monitoring into national M&E tools. So in the future, we hope more patients like Mabaruti can get access to drugs through their peer network. This will not only have benefits for Mabaruti, but will also relieve pressure from her nurse, who will no longer need to attend healthy patients on ART who are queuing up at her health facilities. If you want to learn more about the implementation of CAGs, then please visit our website to download the Community Art Group Toolkit. More information on other models of care involving communities can be found in the MSF report Reaching Closer to Home on samumsf.org.